Moving on to the next lecture, Dil Ki Baat, premature coronary artery disease and subclinical atherosclerosis, the missing link. For this, I would like to invite Dr. Suraj Chavan as a chairperson. He's a renowned practitioner in Baner since 8-9 years. Successfully performed more than 3,500 open heart surgeries at this young age. Founder and managing director at Wisdom Super Speciality Hospital, Baner, which is 100-bedded standalone building, multi-speciality hospital with all the facilities under one roof. Welcome, Dr. Suraj. And Dr. Abhijit Joshi, he is MBBS, MD, DNB, Fellowship, SCI, USA. 3 decades of experience, head of the department and consultant cardiology at Manipal Hospital, Baner. Welcome, sir. May I request the chairpersons to please.
I would like to introduce Dr. Rajesh Badani. He is the Associate Director, Department of Cardiology, Aditya Birla Hospital. He is a DNB cardiology teacher since 10 years. DP Basu Award recipient for Best Original Research across India at CSI Chennai 2008. Past President CSI Pune. Special focus on preventive cardiology. I would like to sir to start his lecture session, please.
All, thank you BMA, and I think happy to be here again, and thanks for the kind introduction. So the topic is going to be premature coronary artery disease. So this means by definition people who get an event, either a coronary event, MI, sudden death below the age of 50 years is what will be by definition we'll be talking. And subclinical atherosclerosis, we already know very clear cut that if you do an angiogram or you do an MRI or you do an MR angio and you identify that there is evidence of involvement of plaque is there, you probably directly pick it up and say he has atherosclerotic cardiovascular disease. But subclinical means patient is harboring the problem, but clinically they are not having any signs or symptoms is what? So basically we need to understand that atherosclerosis is a chronic inflammatory disease of the arteries. This process is a continuing. We have foam cells at baseline that probably converts into a small plaque that can go into a mixed plaque, calcium that can erode. Subclinical is an early indicator. So if you really pick up by doing an ultrasound of the carotid or the femoral artery and you are able to identify that this patient has evidence of minor plaque in any of the vasculature, then that is the time when you diagnose that this patient has a subclinical atherosclerosis. And if you don't pick up, you many a time see patients coming to you with directly an MI and you realize this patient was absolutely stable till now, and why did he get it? Pathogenesis wise, everybody should understand that 75% of all the atherogenic lipids are only LDL is responsible, and 25 comes from the triglyceride rich lipoproteins. So their TG, if they are high, you need to look into that component which is there. And low LDL cholesterol is directly associated with reduced cardiovascular risk. But the only problem that we fail to evaluate is how do we risk stratify a patient of CID. So this is the Lipid Association of India scoring, and if you look at the first part, anybody who is above 45 years of age, he has one risk factor already as a male, and a female who is above 55. Secondly, if you are a hypertensive, that's another risk factor. Third is low HDL cholesterol, and the last is current smoking or tobacco. If you fit into at least one, you are into low risk. If it's 2, you are in moderate risk, and anything above 2, you are in a high risk. Why this is important? All of us are under the myth that LDL of 120, 130, 140 is absolutely fine. So this is the guideline, this is the thing that we need to understand, that my treatment goal starts with 100 in low and moderate risk. So all of us sitting in the audience, 50% of us, all of us will have an LDL of 110, 115, 120, 125. And all of us will feel we are absolutely fine because my LDLs are within goal, which is not the case. If you fit into it, all at least the males who are above 45, and if you are a hypertensive or your HDL is below 40, you already are into moderate risk at the present moment without having diabetes, without having anything else. And the moment you go higher risk, I am not going to go into it 70, 50, 30, and even we are now reaching, because what our body requires in LDL is only 10 to 15. Anything above 15 or 20 milligram % is not relevant and not required by our body. So, and another important thing is there is something called as cumulative impact of LDL. If I am having an LDL from the age of 30 years, which is 140, and that keeps on till 55 years of age. So it is not only the LDL value multiply, like I don't know, chest physicians talk about, pack years, how many smoking cigarettes you do and for how many years you are doing, that is what will decide. So similarly, LDL value multiply by the number of years your LDL has been high will define the atherosclerotic burden in your body. And another thing is, not all CVD risk is modifiable. So if you look at the white part is the primordial prevention. If you have an event, statins are already started, you have to make your bar as horizontal so that over years together you do not reach a cutoff and probably a coronary event doesn't occur in you. This was a young, now coming to young people coming with MI, I just had an opportunity of a 35-year-old male who came with an acute MI. He coincidentally went to my casualty to take loading dose. He had a VF, almost had to shock him 9 times and he was back to sinus rhythm, amiodarone and xylocaine given, and this was his LAD which was 100%. And obviously we did our primary angioplasty, recovered. Patient did not have a single ectopy after that. Patient was conscious completely, no intubation required. But the point is that what is the etiology? What was his LDL value? Was just 71. No smoker, no tobacco chewer. HbA1c 5.3. So now all of us will feel that Baba is a very unlucky guy to have an MI at this particular age. But that's now we finished his plasty, he's all fine, he's gone home. This trial, all of us need to understand from a perspective that if people have MI at a younger age, 9 of these factors will be present in more than 90% of the population, which will be responsible. And number 1 is dyslipidemia. And in that dyslipidemia, it is ApoB upon ApoA1 ratio, which is a little different. Smoking is number 2. Hypertension, mind you, is earlier than diabetes. The risk of hypertension related CAD is higher than diabetes. We know that once person gets diabetes, he has a problem, but you are not away from even a hypertensive patient. Next is abdominal obesity, sedentary lifestyle, lack of green leafy vegetables and fruits also if you are not having, that is also one risk factor. And one important thing is in India, one of the most important thing is B12 deficiency is a cause for STEMI in young Indians. This fellow's B12 was 86, homocysteine was 111, and that was the primary cause. We could have easily lost him if probably he was not there at the right place at the right time. So the interesting part is young people who come with MIs, the difference is no traditional risk factors. Tobacco in any form, many of the people may be taking, so irregular tobacco or smoking even 1 cigarette in a month, you are a smoker and there's no classification in that. First episode of STEMI, very low undetected B12 level and high homocysteine and near normal or low lipid. 71 LDL is bang normal and pretty good, I would say, for an individual. So that is one of the reasons that we need to understand at any young. And there is a literature that homocysteine has direct toxic effects on the vessel wall due to the generation of free radicals, endothelial injury. High homocysteine level produces CAD in Indian patient, and that's a very clear established entity. So it is not only the B12 deficiency, but it is high homocysteine which occurs, which primarily causes direct thrombus for, imagine proximal LAD, recurrent VT, 8 shocks, he would have not made it anywhere, provided it would have been any other place. Even he would have been on the road, we would have only given CPR, he would have not had the opportunity of getting a shock. So that is why this is very, very important to understand. Now let's come to people who get MIs at a young age. What is the difference is something called as a vulnerable plaque. The literature of all this study tells you that red bar, 68% of MIs are in people who have lesion below 50%. You remember the Satara Marathon, one fellow was, I think, a professional runner was running and he died suddenly. Recently there was a Ironman in Australia. I think one of the fellows was swimming. The wife couldn't find him. They started a rescue operation and he was found drowning in the sea. And we've had almost another example a few weeks back in one of the... So point is that the point here is it is directly proportional to plaque rupture. I just need to have a 40% plaque and that has to rupture. Now when will it rupture? Why will it rupture? I think if that we know, then we'll become God and we'll save everybody. What you need to understand here is, in a plaque there is a necrotic, that yellow material is your atherosclerotic material and that thin pink line is the thin cap fibroatheroma. If the thinner the fibrous atheroma, the chances of plaque rupture is high, and that is why any plaque which is below 65 micron has a very high chance of rupturing. Now that you cannot know till I do an OCT study, invasive catheter inside your heart, and I check your plaque, but that's not practically feasible. So we have to understand that how am I going to pick up these group of people. That's why we keep on seeing every day. One fellow came to Birla 2 days back doing excessive gym, had a sudden cardiac arrest, brought dead to the hospital. So all of these are malignant ventricular arrhythmias, but they occur primarily because of a plaque rupture and somebody getting a STEMI, but by the time they get this, they don't have any collateral circulation and probably they get electrical event, which probably they die suddenly. One of the very, very important things we need to understand is a non-invasive modality, not a CT coronary angio, but coronary calcium score. You don't need an IV line, you don't need creatinine, you don't need anything. Take the patient, get him into the CT, get your calcium score by the computer, and you will get a value 0, 1, 100, 200. So you just look at the purple bar. If your coronary artery calcium score is 0, you have 99.4% chance that you do not have any coronary artery disease. The moment the number starts rising at even 1 to 99, you straight away go into a high risk or a moderate risk. You need to start statins there, and that has to continue, and your LDL goal has to be below 70 lifelong. So I think that is important. And the moment calcium score rises, the event rate increases, very natural. There is nothing surprising about it. But a negative predictive value of a 0 calcium score is very important. So that is something, because we are more inclined to do CT coronary angio. Again, we are worried our heart rate is 90. I am waiting from morning to evening. I am taking 2-3 ivabradine. Then still my heart rate is not controlled. So it's not CT angio for a primary prevention. Coronary calcium should be good enough, and that gives you a good amount of information. This is a very, very important 2 studies which are there. That progression of early subclinical atherosclerosis was studied over years together. Bank employees were followed up for 20 years from between the age of 30 to the age of 50. And what does it tell you is they did 6 places they evaluated: 2 femoral artery ultrasound, 2 carotid artery ultrasound, 1 abdominal aortic ultrasound, and a coronary calcium score. That in totality they wanted to know, where do I have a plaque? Is that there or not there? And this is very important. If you look at the upper bar, that 60% of the people of middle age already have a plaque. If you have a plaque, you probably have to start, you go into a high risk category straight away, because that plaque can rupture any time. And if you follow them after 3 years, those plaques have progressed. Like 61% has become 67%. And all of us have to understand that anatomy and physiology go hand in hand. If I have a plaque, the physiology, what is the trigger? Trigger is inflammation. That's why the second test which was done was a PET scan. If there is any inflammation anywhere in the body, you're going to pick it up. If inflammation in the presence of plaque is there, that's a very horrible nidus for this plaque to rupture. Very interesting thing is that I'll come to about the LDL values. There is a very good study that we have telomeres which are there in our body. They are the genetic material. In the telomere, there is an enzyme called telomerase. If your telomerase enzyme is low, that means my telomere height, if it is bigger, because as age advances, my telomere height keeps on going down. It's very simple that by genetic, there's been a very good study from GB Pant, Delhi, that all young MI patients, you do a telomere size and they were all smaller. And they have published that data telling you that people who have smaller telomere size, and their probably lipids and other things are there, they are high risk candidates. Along with that, lifestyle and all, we'll come to it. Brain, these are all additional things. And the last part, vigorous physical activity is associated with LV hypertrabeculation, fibrosis, scarring and all that. So that is one of the reasons that extreme marathon running, if we are talking about, has its own. I am not obviously a proponent or a non-proponent, but please see to it that anything in moderation is better, and that you have to probably decide for yourself. And look at the data. 53% people had carotid plaque, 74% had femoral plaque, 55 had, but coronary calcium score was only 19. So your femoral plaques are much higher. And look at the right side, inflammation is almost in 1/3 of this particular population. So plaque plus inflammation, ACS can cause plaque rupture. This is independent of your LDL level. Its dynamic can occur anytime. Sheer stress means if any aggressive physical activity. I remember a video where a person is playing doubles badminton, and while playing, I think he collapsed. Why? Because for him, that particular game could have been the first game which he's playing over a long time. Or I'm trying to do something aggressive, my plaque ruptures, and I can get an MI or a VF at that particular time. So aggressive gymming, marathon running, acute unaccustomed activity, sudden increased sympathetic discharge, which causes anger, shock and grief. Another thing was lifestyle we are telling. Just a simple thing like skipping breakfast. Just look at the black bar. Subclinical atherosclerosis is in 75% of the people. So lifestyle also is directly proportional to a plaque. And we talk of sleep duration and sleep fragmentation, because we have evidence now that lack of sleep adequate and fragmented or disturbed sleep is directly proportional to a higher odds ratio to have a event or a plaques which are going to be there. And calcium score, we have to understand, alone that is not enough, because the red bar is the carotid without calcium and black is calcium. So carotid plaque are double than of the carotid. So if I do only calcium score and I am normal, doesn't mean my carotid or my femoral doesn't have plaques. But your subclinical atherosclerosis in almost is in 70 to 60% of people. Now another very important, people have a myth, my LDL is 120, nothing can happen to me, which is wrong. Normal LDL are associated with subclinical atherosclerosis in the absence of risk factors. This is very important. People say that, Baba, I am fit and fine, I am running 10 kilometers, my lipids are so and so. This is the data. The moment your lipid is 50 to 60 LDL, that is when you do not have any atherosclerosis. The upper bar is that, the lower bar is no atherosclerosis. The moment your starts rising, this is percentage of people which have atherosclerosis. And look at between 190 to 120, 45% of the people already have plaques. So you don't have to get surprised if a 35-year-old gets an MI or a 40, because we have not evaluated ourselves what needs to be done. So normal LDL, if at all you want to reach where you want to delay your atherosclerotic process, it should be below 70. And if you touch 50, it is unbelievable. Let me tell you, on earth, no individual without a statin can have an LDL of 70, 60, 50. You may be very lucky if you have a genetic deficiency of something where you may have it, but routinely it will be 100, 110, 120. That is how it is. And as I told you, cumulative over a period of time. So this has to be a green bar. At 55, your cumulative LDL is going to be around 150 and above, and your event starts occurring. So it is just not the LDL value. Somebody keeps on having 130 LDL, but he is not doing anything till 55, 60. Then don't be surprised if he gets a plaque rupture in this particular issue. Practical approach. Now I talked about theory. Practically what we can do in our clinical practices is vascular age estimation, central aortic pressure. Can I estimate endothelial dysfunction indirectly? So we have an entity where we probably call it as a cardiovascular risk profiler, where I can probably measure the central aortic pressure, augmentation in the pulse wave velocity. I just have to see my aortic pulse wave velocity in my descending aorta, in my femoral artery, when I use it in my brachial artery, all that probably I can do that. Endothelial dysfunction is the first and the foremost issue that occurs in people, and that generates oxidative stress and all other things that happen in our body. So we need to identify that. So functional vascular age tells me only that if my pulse wave velocity is higher and my vascular age is higher than my biological age, there is something going wrong in my vascular system. May it be endothelial dysfunction, may it be something inflammation, something or the other. But that probably tells me a clue, and then I probably evaluate my lipids and then I probably start statins very early. Today the fear of people is, why should I start statin? The only drug that will delay your atherosclerosis or at least delay an acute event from occurring, or that thin cap fibrous adenoma, to make it hard, it's nothing but statin is going to do it. So in conclusion, we need to understand that atherosclerosis is a progressive thing. All of us are going to have it. ASCVD occurs by 1 to 2 decades earlier in our country. So people getting 65, we get it at 40, and there is a reason for it. Metabolic syndrome, abdominal obesity, lifestyle, everything. Fitness and health is not synonymous. If somebody is fit, that's why all your actors who died suddenly, look at their sleep schedules, nobody knows. Have they done their lipids? We don't know. People died suddenly purely because of plaque rupture, acute coronary event, VT, VF, and they could not be survived. Plaque rupture is the cause of MI and sudden death, but the plaque rupture, the cause for it you need to identify. It is dyslipidemia, it is B12 deficiency. LDL is the culprit behind it. Inflammation triggers the event. Inflammation alone is not, I should have a substrate and a trigger. When both meet together, that's when an event occurs. I may have a substrate, but I don't have trigger, so I'll go on till 70, 80 years till I don't get any other trigger. Subclinical atherosclerosis is the missing link which we are not evaluating our own patients very well. And lowering LDL to below 70 with statins is the key to delay atherosclerosis and any other event that is there. Okay, thank you very much for a patient here.
Wonderful lecture by Dr. Rajesh. To summarize, I think as Dr. Prasad has already told you, there are many things you can diagnose clinically, but there is a huge subclinical or asymptomatic atherosclerotic events going on in the society, and MI being the most common. So in such patients, how do we decide when to start statins, when to start aspirins, and how aggressively we should investigate? We cannot do CT angio for everybody, we cannot do MR for everybody, but simple blood evaluation like lipid profile with lipoprotein little a, that is one missing link. Then homocysteine, B12 levels, and third thing is calcium score, CT calcium score, that is already recommended in American Heart Association Guidelines 2022. Simple CT calcium score, if it is more than 100, you must start aspirin and at least low intensity lipid lowering, and your calcium score is more than 300, strong recommendation for high intensity statins, so that it can bring the risk of atherosclerosis and events. Thank you very much, Rajesh, and it was wonderful lecture.
Thank you so much, sir. May I request the chairpersons to please felicitate Dr. Rajesh Badani. Now may I have Dr. Dinesh Bhogale, sir, Senior Physician and ex-Government Medical Officer, on stage to felicitate our chairpersons.